Welcome. Today we're going to look at how the primary care workforce, and particularly the GPs and their new roles, can start to take a more proactive approach to care, but also using data-driven approaches to case finding. Now, I'm from HN, I'm Mark England, Chief Executive of HN. We're a company that believes in empower patients and sustainable healthcare, originally from Sweden, and we've been doing a large randomized control trial of clinical case management proactive in the UK since 2015. We're part of the National Innovation Accelerator, and our intervention is accredited by the Personalised Care Institute. So during this project, we've worked with Attenborough Surgery, a PCN just north of London in Watford, a very forward-thinking PCN with 31,000 patients on the list. There are 4 surgeries within the PCN under a single list, including the modern state-of-the-art Bushy Medical Centre. It's a very well-led PCN by Dr. David Zemmel. So the problem we were interested in was, who are these high-intensity users that are causing workload pressures within the practice and are utilisers, but also who's not in the practice? Who are the unmet needs that aren't attending the practice? Now, if we start at that population level, the 31,000 patients on the list is quite a representative gender spread, slightly younger population than other areas of Watford. It's quite a young, dynamic town. But then we look at the patients who are actually active. There's only 14,700 patients who are active each year. So less than half the patients actually go into the practice and have appointments in any one year. And you can see within that cohort, there's the distribution of consumption. Now, it would be good to hear Dr. Leitner's views as we drill down into the 1% and 5% highest consumers in the practice.
5% of the population consume about a third of the clinical resource of the nurses and doctors in a population. And the type of patients that make up that 5% who consume a third of the clinical consultation time is a group of people that tend to have physical health comorbidities, multiple physical health problems like respiratory disease, cardiovascular disease, diabetes, etc. But particularly, which came as no surprise to me, with a mixture of not only physical health problems, but mental health problems such as depression. What we haven't yet been able to understand is the social vulnerabilities of that population cohort, which I imagine would be quite significant.
Now, I'll pass you over to Dr. David Zemmel, and who's the clinical director of Attenborough PCN.
But in terms of the analysis, I mean, there's a few things that have really stood out. I mean, certainly, I'm surprised at the ratio of females to males. I mean, in the top 1%. So 67% of our top 1% of users are female, which, whilst I am obviously aware that our females are much more likely to consult, that's quite a big swing and bigger than I would expect. That is interesting to see and suggests certainly that male patients are underrepresented in those groups. And does that mean that we're not accessing males who we need to access, or is it that there are reasons why our female population are wanting to access us more? In terms of some of the other data that's come out, so the year-to-year turnover, again, I'm surprised that there's such a big turnover year-to-year in both the top 1% and 5% of our users. I would have expected most of our frequent flyers, or what traditionally general practice is sort of often called heart sync patients, I would have expected them to actually remain the same year on year. This could be that they are consulting frequently with us in the lead up to some significant medical events, is one possibility, or perhaps it's they have an issue and actually the care that we're giving them intensely over a period of time helps them resolve that issue and then move on independently. The one thing I have thought about just looking at this data is how much of these appointments are actually driven by us or driven by the system in which we work. For example, QOF drives us to monitor long-term conditions, and a proportion of our patient consultations are driven by reminders from us rather than patient-driven. So I guess it would be interesting if there was a way to do so, to actually look at the difference between sort of GP-generated appointments and patient-generated appointments.
I was a little bit surprised by, but is a fascinating insight. Is that there's quite a high turnover of those patients. Actually, that is less faster turnover than we see in secondary care data. But what it means is that we need to have a dynamic, real-time insight into the consumption of different patients in a population, and we need to have a dynamic insight into the needs of that population so that we're able to align the clinical workforce and the multidisciplinary workforce in a practice to the real-time needs of the practice population and the different cohorts within it.
So taking a scientific approach to data-driven care models, the HN started in 2015 a randomised controlled trial with the Nuffield Trust as the principal investigator and local PIs. And with the primary endpoint of the study was to see the impact upon secondary care consumption. The secondary impact was improving patient-reported outcomes, and you can see the very positive results. This is almost a 1,000 patients who were randomised after identification and consenting into the intervention, and you can see the reduction in secondary care and also the improvement in patient-reported outcomes. But subsequently, we've recently had Dr. Jonathan Cohen has written a thesis looking at the primary care consumption of these patients, that we're seeing such reduced levels of secondary care consumption. And if we look at that trend, the green line represents where the patients are actually identified on the secondary care data. So this is a patient that's at high risk of consuming acute bed days, according to the machine learning. But if we look at the two lines before that, this is the 6 months on the horizontal axis, the 6 months preceding that, we can see that both in the intervention and control group, there was no variation in their primary care consumption. So it wasn't shifting that secondary care activity into primary care, it was shifting it right to the left into self-care and self-management, which is positive. But interestingly, the secondary care identification was preceded by an increase in primary care activity in both control and intervention, which gives us the hope that we can, working with Dr. Zemmel and Attenborough Surgery, look at how we might identify those patients proactively before that rapid escalation. And once you found these patients, what do we do with these patients? What is the actual intervention? It's important that in population health terms, you're supporting once you identify. And I'm going to pass you over to Karina, who's our Chief Operating and Nursing Officer, who will talk about the actual work with patients in a primary care setting.
Patients in primary care are more focused on the realities of living with the day-to-day effects of a chronic disease. And so we found for these patients in particular, they do experience high levels of depression and anxiety, more than we see in secondary care. And therefore, to optimise the effects of the intervention, we focus quite heavily on supporting patients through these conditions in order that we can empower them and build their confidence going forward to become more proactive in managing their health. But one of the biggest lessons we've learned is the importance of collaborating across a whole MDT, social prescribers, pharmacy, voluntary services, making sure that we are really integrated within those services, that we can offer a truly holistic solution to patients, integrating both existing and new services into their care to support them further.
So Steve, it'd be interesting to hear your reflections on the potential for data-driven approaches for PCNs.
So I think what is possibly underappreciated is the huge variety of holistic needs within a practice population. There's quite a large proportion of the practice population. In fact, I think we found about a half of the practice population consume no clinical resource whatsoever in a year. As we've just heard, a small proportion, 5%, consume a third of it. So the needs of a population are very varied, very different. And by taking an approach that really understands the different needs within a population, and that doesn't just mean looking at those who are consuming a lot of healthcare resource, because there'll be a significant proportion of the population who aren't consuming as much resource as they need, but by understanding the data, by understanding and being able to interrogate that data of a practice population, and even better, understand the social care data, community healthcare data, mental health care data, hospital data, we will be able to undertake a much more proactive approach to primary care, where we're ensuring that there is less unmet need and we're focusing more time on the people who need it more, partly guided by evidence of their consumption, but also by their needs, even if they're not consuming a lot of healthcare resource at that time.
So as well as that impact on inequality and the unmet needs there might be within a list, I think data-driven approaches to the caseload for the primary care team is going to become more and more important as part of the long-term plan. As PCNs appoint more and more of these additional roles and the workforce grows and becomes more multidisciplinary, That change in culture to be proactive and to deploy these resources effectively means that data-driven innovations, such as the one we've been working through in Attenborough, are going to be critical to delivering the objectives of the long-term plan. That staying well, aging well, and keeping people where they want to be at home with the best possible outcomes.